Dear friends, ladies and gentlemen, it is really a great pleasure and honor indeed for me to be here on the platform of Merck India on a very special occasion. The occasion is very well known to all of you. It's a dialogue with all of you on beta blockers, especially on bisoprolol or Concord. Now, what is the theme of this meeting? I'm sure all of you are very clear that to discuss about the power and promise of beta blockers in CVD and heart failure, and there will be a special focus on bisoprolol or Concord. What is the consensus today? I must tell you that the scenario of hypertension, heart failure, diabetes, and CKD, metabolic syndrome, atrial fibrillation, stroke is known to all of you. India is the world capital. The data published in the Indian Heart Journal is also known to you. 10% of hypertensive people are only meticulously controlled so far as the hypertension is concerned. This is the data from the Ministry of Health, Government of India. It is also data from ICMR and WHO. 42% of hypertensive patients who had existing hypertension were not aware that they are hypertensive. So this is a real issue and we are deeply concerned. Uncontrolled hypertension, uncontrolled diabetes, uncontrolled dyslipidemia is a precursor of heart failure with preserved ejection fraction and heart failure with a reduced ejection fraction and premature CAD. My emphasis today is on sympathetic overdrive. That's the main issue which I am going to discuss with you in next few minutes. Because it is the SNS which is a common feature in hypertension, heart failure, coronary artery disease, and metabolic syndrome, tachyarrhythmias, along with activation of RAS system and NPS. What is the consensus today? Sympathetic overdrive with increased SNS is responsible for a very high morbidity and mortality not only in India but in the whole globe. Achieving a target heart rate, optimizing the norepinephrine surge, thereby help us in reducing CVD morbidity and mortality, especially in hypertension and heart failure. We have a huge, focused, robust data, and you all are aware of. The most powerful data is from CBIS 1 in 1994, CBIS 2 in 1999, CBIS 3 in 2005, MR-FIT trial in heart failure in 1999, Capricorn in 2001, Copernicus in 2001, Comet in 2003, and Seniors in 2005. Meta-analysis data in 2016 and Trivandrum heart failure registry data in 2018, ESC, AHA and ACC guidelines in 2021 have given us a very, very clear-cut information about the usefulness and power and promise of beta blocker, especially bisoprolol. You all know that metoprolol is 44-year-old molecule, while bisoprolol is 31-year-old molecule, and carvedilol is 28 years old molecule, while nebivolol is only 26-year-old molecule. Now, what is the uniqueness of beta blocker is a point which I am going to discuss in the next few minutes. Now, if you see the beta blockers, bisoprolol, metoprolol, and nebivolol are beta 1 selective, out of which bisoprolol is beta 1 super selective. So that's the power of bisoprolol. Now this Trivandrum heart failure study has shown us very clearly that the 5-year mortality rate is about 59% in the patients of heart failure. That means almost 60% of patients die within 5 years after the diagnosis. And sudden cardiac death is 46%, which is a huge data. And those who received medical guided treatment, the survival is better, 25%. So beta blocker reduce the mortality by 45%, which is a very, very relevant information. So beta blocker reduce CVD by 29%, all cause mortality and morbid by 33%. Sudden cardiac death reduction is highest with beta blockers. Out of these beta blockers, highest with bisoprolol. As mentioned in series 1, series 2 and series 3, to a tune of 34 to 39%. Ladies and gentlemen, beta blockers also reduce the hospitalization with heart failure, worsening of heart failure, and take care of tachyarrhythmias, and responsible for reversal of cardiac remodeling, reduce the event rate, and there is a robust survival benefit with beta blockers. Target heart rate reduction with target dose of beta blockers definitely reduce the non-epinephrine surge. The optimum heart rate which is required should be more than 55 and less than 64 at rest or change in posture with a routine activities, but may be slightly higher in atrial fibrillation patient. The target heart rate achievement is a main goal of treatment in the patients of a heart failure. You should also know that beta blockers is a drug of first choice out of 5 pillars of heart failure. A very powerful, robust data on sudden cardiac death reduction is known by beta blockers. And the beta blocker also play a very important role, as I mentioned to you, on the reversal of remodeling, especially LABI, reduction of E by E prime ratio, NT-proBNP, left atrial strain, even the left ventricular global longitudinal strain, pulmonary artery pressure, MR, and improvement in the ejection fraction. Dosing of beta blocker should also be known to all of you. If you take bisoprolol, the maximum dose is 10 milligrams OD, metoprolol 200 milligrams OD, while carvedilol is 25 milligram BD in most of the trials in almost 19,205 patients. 75 trials I reviewed of beta blockers when 95,000 patients showed a reduction in the mortality, which is of CVD mortality, all-cause mortality, and sudden cardiac death. The most powerful promise and potential of beta blocker, especially bisoprolol, is a reduction of sudden cardiac death, which is a very, very powerful potential of beta blocker. Should be known to each and every one of you. Achieving optimum heart rate is a surrogate marker of mortality and morbidity reduction in heart failure. Survival benefits in target heart rate depend not only on the dose, but also depends on the sensitivity of the CNS. If the patient's CNS, SNS is reduced, activities are there with the beta blocker, we consider heart rate achievement is more important than the dose. This is a very important message. Sudden cardiac death reduction higher with beta blocker, especially bisoprolol. I mentioned to you 35 to 40%, as compared to ARB, where sudden cardiac death reduction is only 15%. By ARNI, SCD reduction is 20%. By MRA, it is 30%. By AC inhibitor, it's only 1%. See the promise. So sudden cardiac death is a very, very important power which you have to understand. Beta blocker is on the top for reducing sudden cardiac death, especially bisoprolol. Now, this every one of us should know. What are the indications of bisoprolol? Beta blockers? Hypertension, young patients, middle-aged patient, or old age, with or without comorbidity, are indications of beta blockers, because most of them have enhanced SNS. Second, heart failure. Heart failure with reduced ejection fraction, heart rate with heart failure with mid-range ejection fraction, heart failure with improved ejection fraction are indication of beta blockers. So far as HFpEF is concerned, it needs further evaluation and revalidation. Another indication of beta blocker is cardiomyopathy. Ischemic cardiomyopathy or non-ischemic cardiomyopathy. COVID infected cardiomyopathy, Tokosubo syndrome, very important. Septic cardiomyopathy, pericardium, peripartum cardiomyopathy, amyloidosis, sarcoidosis, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Even the patients who have Marfan syndrome with dilated aorta and aortic regurgitation and mitral prolapse, beta blocker is a drug of choice. Tachyarrhythmias, especially supraventricular tachyarrhythmia. When a patient has got atrial fibrillation, this is really a very, very important drug. Sympathetic dysautonomia. Only yesterday I had a patient who was about 32-year-old who had a sudden onset of palpitation with redness of face, sweating, and he was brought to me. By the time he came to me, his ECG was normal. But he definitely had a dysautonomia. I did an echo and I found he had a mitral valve prolapse. He had two such episodes in the last 2 months. And I'm going to do an Holter and try to see what is the cause of his sudden palpitation. Is it really PAT or atrial fibrillation or a sympathetic dysautonomia? Mitral valve prolapse, we see large number of patients. 40% number of patients in female are having mitral valve prolapse with tachycardia. They are all candidates for drug like bisoprolol. Hyperthyroid, anxiety state has an increased or enhanced SNS. Then mild COPD, Concor can easily be given. It's very important. In migraine also, we use a number of patients. What are the contraindications? Should be known to each and every one of you. Heart failure with no systolic dysfunction, we don't give beta blocker. Hypotension, when the systolic blood pressure is less than 70, or bradycardia, when the heart rate is less than 50, severe asthma, or when there is a peripheral arterial disease. Now a very important point we are going to discuss. What is the uniqueness of bisoprolol? Bisoprolol is a unique, iconic molecule of the century. It is like a gold standard. It is superior because of beta 1 super selectivity. It is metabolic friendly, does not affect the lipid or carbohydrate metabolism. Pharmacokinetically and pharmacodynamically, it is more friendly. 31-year-old molecule is bisoprolol and 44-year-old molecule is metoprolol. Robust survival benefit has been mentioned in the literature on all the guidelines. CVD mortality and morbidity in heart failure is significantly reduced with beta blockers because SNS is hyperactivated. On the top, there is a reduction of sudden cardiac death. As I mentioned to you, the beta blocker is superior as compared to all the agents available today, whether ARBs or ARNI or SGLT2 inhibitors for reduction of sudden cardiac death. No erectile dysfunction. This myth should go with the beta blockers, and there is no cognition problem. Bisoprolol is a beta blocker of first choice in hypertension, resistant hypertension, heart failure with reduced ejection fraction, tachyarrhythmias, and cardiomyopathy. Thank you very much for giving me this honor to interact with you on this platform of Merck India. Ladies and gentlemen, I also express my gratitude and thanks to Mr. Dilip Patil, Director, Business Unit Head, Vinita Gaur, Head of Marketing, Dr. Harshal Chaudhary, Head Medical Affairs, and each and every one of you from the Merck India. And lastly, I must say in my concluding remarks, we must act vocally, focally, locally, and impact globally. We must inform, perform, reform, and transform the whole world with the awareness of SNS activation and the role of beta blockers, especially bisoprolol, to reduce CVD infected morbidity and mortality. Thank you very much for giving me this opportunity, and thank you for your kind attention.